Huge honor, not only to share the stage with legends and with mentors, but really to be in front of this great audience. It's so nice, each break, questions, showing the cases, exchanging the meanings, and this is what it makes really so especially. Finally, I don't have to explain where I'm coming from after this World Cup. This is Luka Modric. This is Luka Modric, the best player of the World Cup, and this is Luka Modric hoarding the gods. He's grown up in Croatia on countryside, and so am I. Of course, I played also with girls and with the dolls, but I desperately wanted to join the boys. I loved all these, all these secret missions and ethical codex, hard trainings, but they didn't want to have me. They wanted me only to provide them with the food, with bandages, just, to nurse them. And I succeeded in making some vehicles and weapons for them, and I also dreamed about it to become a famous inventor. But do you remember this feeling from your childhood that everything is already invented? You do. Maybe also because I come from this tiny country, and all small countries are very, very proud on big people coming from there. And one of them is Nikola Tesla. And he really invented everything. Nothing left for us. So I became simple Robin Hood, very skilled, very creative to organize bandages and food to take from the rich, from my parents' house and my neighborhood, and to give to the boys. It wasn't that easy back in socialism to get bandages. And this is attitude that I kept also in my daily surgery. I followed the rules. Take from the rich, give to the poor. Don't waste autogenous material. Donor and recipient side should be the same or almost the same. And be minimally invasive. And I love non-autogenous tissue, but it's not religion. And if there is something I can take from the bottle, and it has the same outcome and less morbidity, it's warmly welcome. And I keep trying, combining, looking, and of course, reading literature. Here are some examples from Robin Hood approach to hard tissue surgery. If an implant is fractured, we cannot take it out utilizing explantation kit. But we can apply Curie technique, take out the bone plate, take out the implant, and then stabilize the bone plate even more coronally, even more buccally, and this way not only preserving the site, but at the same time doing site enhancement. Or the sinus window bone plates, especially for the patients where at the same time sinus elevation should be done and they are in need of ridge augmentation. Sinus window bone plates work very, very nice. Or think on the situations where the ridge is very thin, but the vertical dimension is sufficient, mostly in anterior mandibular. Why to go to the ramus? Why to go to linea obliqua? We can simply cut off this upper part of the ridge and stabilize it in the Curie technique. It works very nice, and patients hardly take painkillers, really hardly. Or tooth grinding. It's the best recycling in dentistry ever, and it became really honestly my favorite grafting material, and I'm not the only one. And I really tried to give a structure to this playful topic, not only to turn the pages now with the cases. And so it's divided into periosteum, free gingiva graft, connective tissue graft, triplex graft. And there is something especially with roll flap, palatal and buccal sliding flap, and I couldn't avoid a little bit of everything, as Mark Bishara called it. A little bit of everything is also here. Periosteum. It was spontaneous decision of me to utilize periosteum for the first time. I was about to do a coronally repositioned flap, to utilize connective tissue graft to treat these recessions like usually, and I left apically periosteum with more connective tissue on top of it to make later suturing of connective tissue graft easier. And then all of a sudden, I looked at this material and thought it's really pity to waste this material. I can actually utilize this periosteum. It's great material. It has pluripotent stem cells. It has great vascularity. And even it has growth factors. So I pediculated and rotated periosteum flap and stabilized it over this recession. In this particular case, connective tissue graft was already harvested, and so I utilized it also. And I thought, wow, Snježana, great idea. But my friend Nikola Tesla came only to say, nothing new, it's not your idea, already published. And meanwhile, I learned that there is quite amount of literature comparing also periosteum to connective tissue graft for recession treatment, and showing that it is good material with the authors claim, same percentage of recession covering, and patient acceptance is better because donor site and recipient site are the same sites. And there is also not limited amount of periosteum that we can utilize for recession coverage is not limited. And also speculation that because periosteum is a rich source of stem cells, there is theoretically possibility to get a new attachment during the healing. So I kept to utilize periosteum flap, and here one case, this right canine in the low jaw, patient 24 years old or young. He has already had 5 years orthodontic treatment. No way to persuade him for another round of orthodontic treatment. Double papilla flap was done, and only periosteum pediculated pedicle flap. And this is how it looks like after 10 days, after 2 months, and then finally after 6 months. It works really nicely, and this is really minimally invasive. The recipient site and the donor site are the same. This is the beauty of this periosteum flap. And so another version of this pedicle periosteum flap is PET. It's not partial extraction therapy, it is periosteum eversion flap. It means that after the split thickness flap is done, on the basis, one horizontal and 2 vertical incisions are done to inverse periosteum over the root surface that should be treated, that should be covered. And some inserts from the surgery, and it looks really nice. It can also be utilized for multiple teeth. It's okay. The achieved soft tissue thickness is not like when we utilize connective tissue graft, but it seems that it is stable through the time. So we came to free gingiva graft. Just a few words to free gingiva graft. It's routinely utilized, how we told already a lot of it. It is routinely utilized together with apical repositioned flap for vestibuloplasty. And since one of Robin Hood rules is be minimally invasive, I avoid big surface free gingiva grafts and try to utilize more strip gingiva grafts. to reduce patients' morbidity. Although the literature doesn't support this, my opinion. The literature says the donor site mobility doesn't depend on the graft surface area, but only on the graft thickness and thickness of the residual bone on the bone surface. But the healing after harvesting of free gingiva strip grafts is faster than if bigger surfaces gingiva grafts are harvested. My two students, Monika Kecha and Matko Ogoic, they improved further this technique, adding PRF. Gingiva strips and PRF just to improve soft tissue healing and to cover this exposed tissue. And it works really nice. We are utilizing it very often. I also try to test other materials. Here, one side, the right side, is done with the free gingiva graft and the left side with collagen matrix. Because the literature said collagen matrix, xenograft, works almost the same like free gingiva graft, but it looks better on the right side, free gingiva graft side. Also, collagen matrix gives better color matching, and it is less invasive, and the surgery time is reduced. Can we avoid at all free gingiva grafts or connective tissue grafts or gingiva strip grafts? Let's see in this case. This is case we are all very, or most of us, very familiar with this situation. Mucogingival junction displacement after extensive hard tissue augmentation. And the first step after the healing implants were placed, and then first connective tissue graft was stabilized over the top of the ridge. And part of this, together with implant placement, part of this connective tissue graft is left exposed because it survives, and 20% we can left exposed. And this way we got more keratinized gingiva and deeper vestibulum. And now implant uncoverage procedure, and this is simply called modified apically, excuse me, repositioned flap. It means simply that the first incision is not done like usually on mucogingival junction, but within the keratinized gingiva. This way, we get a strip of keratinized gingiva, and when the mucosa flap is repositioned apically, we do have a band of keratinized gingiva apically. There is a band of keratinized gingiva coronally. So all around keratinized gingiva to colonize this exposed vestibulum. Gingiva strip harvesting is avoided, and it works very well. And this is published already 20 years ago, but somehow totally underestimated. And meanwhile, although this technique gives nice result, very nice color matching, look at this particular case. It is a nice vestibulum depth and nice color matching. 20 years ago, it was published, and it is very easy. It requires only 2 millimeter keratinized gingiva buccally, and then 0.5 or 1 millimeter keratinized gingiva can be replaced apically. Very good working technique. As Hovi already emphasized, and as we all realized yesterday again, we are missing consensus, and we are missing clear guidelines. And we are especially missing clear guidelines about soft tissue management, depending on initial situation, hard and soft tissue situation. This is a very nice algorithm that expert Narayan Venkatraman posted on Forum Dental XP. We just had a discussion, and he distinguished practically between initial situation with more or less of 2 millimeter keratinized gingiva buccally and 1 millimeter lingually. And for example, if there is less than 2 millimeter keratinized gingiva buccally and hard tissue augmentation is required, soft tissue should be augmented before hard tissue is going to be built. And some other, I've seen you have already taken pictures, really good algorithm. And Narayan agreed with me that one parameter is missing. And this is what Howie mentioned. It is soft tissue thickness. Because we talk all the time about the width of keratinized gingiva, and we forget the soft tissue thickness, especially for edentulous jaws. We see it already during implant osseointegration, especially when patients are wearing mucosa-supported prostheses, there is already some crestal bone resorption. And if the, of course, all other parameters, but also if the soft tissue, vertical soft tissue thickness is sufficient, it can be minimized or avoided. And this is very effective technique to improve soft tissue thickness, and they do it whenever possible before implant placement or together with implant placement. And this is just in tunnel technique. Collagen matrix is introduced into the tunnel. Where I have learned this technique, of course, on Dental XP. And who is the author? The good-looking man from the first row, Ryan Kazemi. Really good technique. It's so easy. It takes 5 minutes. It doesn't hurt. Soft tissue is improved. It is thickened. And then later, in second stage surgery, when we are uncovering our implants, then we can do all vestibuloplasty and taking care about amount of keratinized gingiva. We do have our soft tissue thickness. It works really good. And this is one slide that I have already thrown away. Trimming my presentation, I have to go to speak faster. But then Craig Bish motivated me yesterday to put it here again. And I think that is an important information because we really tend and start to utilize PRF, PRGF, whatever, instead of bone, instead of connective tissue or soft tissue. And it can be used instead, at least not in split thickness technique. Look at this study. German authors have done, Schlee and his other authors, and they placed implants in split thickness technique. It was a test group, control group, sorry, and control group test group was split thickness technique, implant placement, and soft tissue thickening utilizing PRF. And look here, they had to terminate the study for ethical reasons after 10 days because it caused a lot of soft tissue shrinkage. It was even worse. I think it is important information. I actually don't want to decide between should I increase amount of keratinized gingiva or should we thicken the tissue. I want to have both of them. And a good way to have both of them is connective tissue graft. Before we place implants, before we augment the tissue, it's simply connective tissue graft. It gives thickness, it gives keratinized gingiva, and then later on at implant uncoverage, we can do modified or apically repositioned flap, and everything is fine. I prefer connective tissue graft over free gingiva graft also because donor site morbidity. And this diagram shows really clearly that 3 days after free gingiva graft harvesting, it hurts much more than after connective tissue graft harvesting. And so we came to connective tissue grafts, and I'm going to talk about 5 interesting facts about connective tissue graft, 5 recipes for connective tissue graft preparation, and 5 favorite ways to stabilize connective tissue grafts. let's see some interesting facts about connective tissue grafts. Connective tissue graft shrinks, but it expands also. And it does not matter on which side is periosteum. And it does not matter at all if periosteum is included or not. And the connective tissue graft can be utilized to repair intrabony defects. And reharvesting gives better connective tissue grafts, better volume and better quality. Nothing new, connective tissue graft shrinks. Good news, 2/3 of this shrinkage occurs during the first 4 to 6 weeks of the healing. And there is more shrinkage if connective tissue grafts are thicker. But connective tissue graft expands, unfortunately. And this is especially tuberosity connective tissue grafts. This is my patient with keloid, and this is the second one. Also, tuberosity connective tissue graft, it is 6 months after prosthodontic treatment. It was 2 years ago. I've never seen this patient again, and I can't tell you what happened with this keloid, but it's not very aesthetically. But this patient I've been following for 6-7 years now, and I have also tried a few years ago to reduce this keloid with very modest result. It stays there. Patient doesn't care. I really don't like it. It is a little bit better in time, but not so much better. And this is what the Italian group of the authors have also found out, and saying that plastic surgery actually doesn't help. It is the thickness of the oral mucosa with tuberosity connective tissue grafts was too much 1 year after surgery. You see, 1 month after surgery, 6 millimeter, 1 year after surgery, 7 millimeter. And then plastic surgery was done. It was reduced only to come again. And this is what we see in daily praxis. So let's say in another patient of me, the authors, this Italian group, they have done gingivoplasty to reduce keloid. And I have done also in previous case gingivoplasty, and it didn't work. In this case, the right implant is post-extraction implant, the left is late implant placement with connective tissue graft, tuberosity graft. And this is how it looks like after 3 months, and this is how it looks like after 6 months. Patient has a really low lip line, but she really does not like it. She really forced me to take it away. And I explained to her, I can try it, but literature says it doesn't work. And my own experience also, it doesn't work. But she really wanted me, and she was also scared that it can be some pathology. So I haven't done like usually gingivoplasty. I opened a buccal aesthetic flap and took out everything fibrous that I could take out, and it seems that it is a progressive stop. It is 6 months after the surgery, and last week the patient was here. She came in her vacation just to let me take a picture to show you. This is now 9 months after the surgery. I hope it's going to stay stable like this. And the same group of Italian authors, it is all the time the same paper, they say that tuberosity connective tissue graft shouldn't exceed more than 3 millimeter. Also, the basis for this conclusion is very weak. Altogether, 14 patients, some of them with palatal connective tissue graft, some of them with tuberosity. It is a very, very little collective to come to conclusion like this. And palatal or tuberosity. This is so good design study that I really had to present it. Is Peter here? Peter Amin, hi. Another expert. Look at this study design. Altogether, 40 soft tissue grafts were harvested. 20 free gingiva grafts and 20 connective tissue grafts. Out of 20 free gingiva grafts, 10 were harvested from the palate, 10 from tuberosity, and the same for connective tissue grafts group. And then the recipient side was always mandibular. To exclude any influence of recipient side's morbidity. And I think if study has design like this, and there are many other factors, but Peter is going to present it by himself one day. And if study is done like this, I think we can really trust. And this is the conclusions are that it hurts less if tuberosity connective tissue graft is harvested. The greater soft tissue volume is achieved, but there is no significant difference in recession coverage between tuberosity and palatal grafts. And this is what we also see in our daily clinic. For connective tissue grafts, it doesn't matter on which side is periosteum. If you're going to do recession treatment, we can turn it both ways. And I think this is one of major reasons why I prefer connective tissue grafts over free gingiva grafts. I don't know how many times I spent staring at a piece of free gingiva graft and trying to tell on which side is epithelium together with my assistants. And don't tell me I'm the only one. Harris published a paper, 80% of all de-epithelialized connective tissue grafts are not de-epithelialized thoroughly at all, completely. And with connective tissue grafts, there is not this problem. And it's also interesting that it does not matter at all if periosteum is included. Despite all of these fancy features of periosteum, you know, stem cells and vascularity and growth factors. And look, another expert there, ubiquitare everywhere, Omid Mogaddas, his father also, and a group from their research group, they studied connective tissue graft instead of the membrane for the treatment of intrabony defects, together with biomaterials. And they came to conclusion that it doesn't matter if periosteum is included or not. Strange, but true. And when we are talking about intrabony defects, this is my case with very, very spontaneous treatment planning. The patient came very early in the morning. She is a family member of a colleague. She has taken, I think, weeks antibiotics and came with subacute inflammation, a deep pocketing between the central and the lateral incisor on the right. And then I knew, when I'm going to do a deep scaling, papilla is going to shrink. And then I'm going to do regenerative surgery, and papilla is going to shrink further. So exclusively for this patient, I thought, okay, I'm scaling it, but at least I would like to add something. How we say it, Curie says, salt and pepper. I thought at least Emdogain. But the Emdogain is the proteins from the blood are competitive with Emdogain, so I had to visualize this root surface and to get it blood-free. And for this reason, I utilized this VISTA approach. So I could apply my Emdogain, and then I thought, now I could add also tuberosity connective tissue graft like space holder to prevent this papilla from shrinkage. And it worked. Although it is a family member of the patients, this is how it looks like 3 months after surgery. And I posted it on, of course, Forum XP. It was 7 months after the surgery was done. And this is how it looks like 3 years after, very stable radiologically and clinically. And here I have to cite Chuck Swimmer, who is never tired of saying connective tissue is the best repair tissue. Connective tissue protects the bone. And I cite Chuck often. And then another expert, Sharif said, is Sharif here? Was yesterday? Okay. He improved further this technique utilizing biomaterials. And Sharif, our friend Nikola Tesla, came over just to say, too late for publishing. It's published because he planned to publish. It's published 2018, a new papilla preservation technique. Okay. Nikola Tesla, everything is already invented, I tell you. And another interesting fact about connective tissue grafts is that reharvesting 9 weeks and longer after the first harvesting gives not only better quantity, this is what we see, the volume, but also better connective tissue graft quality. And now finally 5 recipes how to prepare connective tissue graft. Connective tissue graft can be folded. And this is, like after traffic accident, we used to slow down for half an hour, 10 minutes, 5 minutes, but we slow down. And this is each time when I see a patient with keloid of me, I go exclusively to the palate, at least 1 week. And if more 1 week, and if more volume is needed, then I use to fold connective tissue graft. Is it something new? Of course, it is nothing new. It is already published 2004. Gasparini published it, already invented. And it can also be stretched. And it is very handy if longer distances should be treated with connective tissue graft. It can be very good stretch. And it can also be sliced. And this connective tissue graft slicing is the secret behind my full arch recession treatment with 1 piece of connective tissue. It is sliced connective tissue, and it's enough for the full arch. And connective tissue graft can be opened. Another recipe, especially tuberosity connective tissue graft. This is a case of the patient after extensively hard tissue augmentation and modified apically repositioned flap, or the first incision for this flap was done, and then tuberosity graft was introduced to give more volume for the soft tissue. The part of it is left exposed to get more vestibulum depth, and individual healing abutments, again, expert Ioannis Vergolis, who is patented these VPI cervical healing abutments. And this is how it looks like after really bone block surgeries and just 1 soft tissue surgery to get here. But patient had a great tuberosity, and it's not always the case. Connective tissue graft can be draped, and this is especially true for pedicle connective tissue graft, and I never miss opportunity placing an implant if adjacent site is implant with this metal rand. Then I just drape this connective tissue. Sometimes it works, sometimes it doesn't work, but at least this peri-implant soft tissue is augmented and it is enhanced. How to stabilize connective tissue graft? This is my favorite procedure because connective tissue graft is pressed to the basis, and there is less exudate and better diffusion, better nourishing, better blood supply. And it can be suited together with overlying buccal flap or separately. And this is very handy if we need to stretch a little bit connective tissue graft, if we are a little bit short with connective tissue graft. And also healing abutments can be utilized. And I left the screws and pins for Jorge Campos Aliaga, who is going to give a lecture at the Winter Symposium. This is not the connective tissue graft, this is free gingiva graft. And some authors claim that if cyanoacrylate is utilized to fixate, to stabilize free gingiva graft, that there is less shrinkage and less pain and shorter surgery time. I've done it even to see if it's really like this. I utilized it a few times. I wasn't very impressed. And this patient has very similar situation on the left and on the right. On the right side, the free gingiva graft is stabilized utilizing cyanoacrylate, and on the left side, utilizing the sutures, conventional way. And really very similar initial situation, and it looks a little bit better for sutures than for cyanoacrylate. And I can tell you, this cyanoacrylate, it is so hard, and then it gets so hard. When it is in mucosa that moves, it hurts, and the patient tells it hurts. It's better with the sutures. What I do a lot regularly is just suturing connective tissue graft to overlying buccal flap. If it's a single implant site, it's enough to go through the flap, through the connective tissue graft and back. If it's a longer edentulous area, it is safer to suture connective tissue graft first to the buccal flap and then to close the wound afterward. And what I'm doing regularly after bigger ridge reconstructions, at the time of implant placement, I place connective tissue graft and stabilized it on the top of the ridge to enhance vertical soft tissue volume. And then again, remember, reharvesting gives better connective tissue grafts. And again, at implant uncoverage procedure, connective tissue graft sutured to the buccal flap to enhance the buccal soft tissue volume. Like in this case, and then VPI healing abutments, and it looks really, really nice. Let's see a little bit of everything, just a little bit of everything. It's nothing new. I don't show Nikola Tesla, we know it's nothing new. That granulation tissue and connective tissue from the socket can be utilized for the primary socket closure after the grafting. And in this case, patient came 5 months after the implants with huge defects were taken out, and still connective tissue and some granulation tissue in the defects. And I augmented these sites and utilized the connective tissue grafts to enhance keratinized gingiva width, the thickness of keratinized gingiva, and by lefting parts of connective tissue grafts exposed, also the coronary flap advancement was reduced. It shouldn't be thrown away. And by the way, when we are harvesting connective tissue graft, at the same time placing implants or uncovering implants, it's better to left a strip of connective tissue and the epithelium on top of it adjacent to the implants. Why to take it away? It can be, and if some autogenous bone harvesting is required, it can be harvested from the same site. The same donor site, recipient site for all these steps. Epithelialized connective tissue grafts work perfectly for ridge deficiency. And I love them if I can harvest them from tuberosity or posterior maxilla. But harvesting from the palate, it's not difficult for us. It's hard for the patient, because it really, really hurts after the harvesting from epithelialized connective tissue graft from the palate. Often it's overseen that the retromolar in mandibula, there is often enough connective tissue, epithelialized connective tissue, that can be utilized at implant uncoverage to enhance soft tissue. Epithelialized part is left exposed, connective tissue is underneath the flap, and it works very nice. And to avoid this epithelialized connective tissue graft harvesting from the palate, this combination works very good. It is collagen matrix sutured to the flap, to the buccal flap, connective tissue graft on the top of the ridge, healing abutments, guided soft tissue augmentation, and part of connective tissue can be left exposed, and it works really good. And it is a good supplement for this epithelialized connective tissue graft to avoid harvesting from the palate. Combination collagen matrix to thicken the buccal tissue and the connective tissue graft on the top of the ridge. It works really well and it doesn't hurt, especially if connective tissue graft is harvested in a single incision technique. Or in this patient case, Vista approach was done for recession coverage and pontic site development, and here is also connective tissue graft combined with the collagen matrix. Vista approach, and first connective tissue graft is introduced more coronally and collagen matrix more apically, and just one surgery, some tissue, Vista approach, it works really nice. Triplex graft, one of my favorite grafts. I can't show you now long-term results, but it looks really like it's going to be stable because I also started 2 years ago with utilizing triplex graft. Actually, it should be called quadriplex graft because it contains bone, periosteum, connective tissue, and epithelium. It's harvested from tuberosity. And let's simply see 2 cases. Big case, upper jaw, a lot of partial extraction therapy later. Okay, look at this concavity, look at this ridge defect, and then exposed implant. Triplex graft was harvested from tuberosity utilizing these concave chisels and unfortunately hammering a little bit. This is a dark side of this graft. And then this graft was shaped to be wedged into the defect, into the recipient site. And only one screw was necessary to fixate bone to the bone, epithelium to epithelium, connective tissue to the connective tissue. Recipient and donor site protected with PRF. And this is how it looks like radiology, and here is the healing. I only regret that I haven't treated this recession. I haven't thought about it. And is it something new? It's nothing new. The epithelium bone grafts are known for socket preservation. I couldn't find in the literature these grafts utilized for such a big defects, but I'm sure my friend Nikola Tesla knows more about it. And they work very good in combination with partial extraction therapy for the socket missing buccal bone walls, for the sites with missing interdental bone, and for pontic sites and for implant site development. As I already said, it was PET for the upper jaw. I'm going to show this case at Jornada in November in Madrid. And look at this low jaw, this tissue. Only one surgery. Only one surgery, this triplex graft from tuberosity. It didn't hurt. Really, tuberosity is forgivable, and it worked great. And another case, similar, 2 implants exposed, treats exposed, no keratinized gingiva, and here implant placement was planned. Again, triplex graft, connective tissue to connective tissue, bone to the bone, and that spaces I filled with dentin autograft. We just grinded these teeth and utilized it also for defects in the lateral mandibula. And this is after it healed. No resorption at all, implant placement. just collagen matrix to enhance soft tissue volume. And the last time I've seen the patient 3 weeks ago, it was implant uncoverage with modified apically repositioned flap and collagen matrix. Patient didn't came for 1 year because she had a terrible accident. Again, initial situation compared to the situation that we received. What is especially with the roll flap, palatal, and buccal sliding flap? Why this section here? It is one of my cases with soft tissue punch technique, one that succeeded. I have very mixed experience with soft tissue punch technique. I don't know what's your experience, but it failed very often in my hands. And this case was done 13 years ago. And after the implant placement, I planned modified roll flap for implant uncoverage procedure. But all of a sudden, I realized that my first crestal horizontal incision was not done correctly. It was done all the way to the bone. No way to get modified roll flap out of it. Of course, I could have harvested connective tissue, free connective tissue graft, and put it in the buccal tunnel. But I somehow insisted on a flap that is pediculated. I was so angry about myself. So I split it coming from the apically and stretched this connective tissue over the implant, stuck it underneath the buccal tissue, and lucky me, it healed really nice. Is it something new? It is coronally positioned palatal sliding flap, Nikola Tesla says. Nothing new. And this flap is very good to avoid or to reduce coronally flap repositioning of the buccal flap. When we are doing ridge augmentation, and then to avoid the coronally flap repositioning or to reduce it, the palatal sliding flap can be utilized. Full thickness flap on the palatal is elevated, and then the splitting coming from the apical. And this is this tricky part. And there is a really risk of perforations. And I think this instrument, this blade, Halohovi, wake up, that you have shown is going to be handy for this splitting coming from. It is a lot of upside down job to split this flap. It is only for minor and moderate flap advancement. And it can also be utilized to cover the inter-implant spaces. Let's see another case, DSD syndrome, and after both of these implants were, taken out, coming back. Okay. Again. These implants were taken out, a huge vertical defect, palatal and buccal, and not only this defect, but very, very narrow ridge. It's really narrow ridge. Tissue reconstruction, it is from yesterday, titanium mesh and sinus window bone plates for the posterior area. And this is how it healed, and now soft tissue part. I utilized few techniques in the same procedure. First, guided soft tissue augmentation. Healing abutments are placed on the implants. Then, thin gingiva is augmented with the collagen matrix, some PRF, and this coronally sliding palatal flap. This part of connective tissue is left exposed to minimize or to reduce, in this case, completely coronally flap repositioning. And this is how it looks like after the initial situation with this thin ridge and huge defect, titanium mesh, sinus window bone plates, and one soft tissue surgery, not that much. I think it's not that much, and it works really nice. Let's see guided soft tissue augmentation. Dr. Salama was so kind, and after my nervous breakdown in Paris, when I didn't make to Florida, he gave me actually his lecture time. And let's see together the guided soft tissue regeneration or guided soft tissue augmentation. It's genius. And I'm so sorry, that's not me that came with this technique. I love everything that is Robin Hood. It's tricky. It's just placing healing abutments on top of the implants and primary closure. And what do we have? We do have a clot. What do we have? We have soft tissue. We have a connective tissue. The palatal sliding flap can also be utilized to cover the bone between the implants. Okay, let's go back to the case. You remember that I screwed up, I have done not correctly my first horizontal incision, and then when the patient came back for implant uncoverage, finally I was focused and I've done a modified roll flap. Roll flap is introduced by Abrams in the literature, and Abrams used to de-epithelize palatal connective tissue that is going to be underrolled under the buccal flap. And it has disadvantage because the bone is exposed after de-epithelization. And then Scharf and Tarnow modified this technique and started to split this palatal tissue, and this way no bone is exposed. This is technique that works well. It gives a really nice soft tissue volume. It can also be modified. Everything can be modified. And if our goal is here to have more vestibulum depth, and but also not also to keep more buccal soft tissue thickness, a part of this flap can be left here exposed, here modified Palaci technique, and if it's done like this, only one soft tissue surgery and the soft tissue volume is improved, and we have more vestibulum depth. I do rather a lot of roll flap technique, but only in non-aesthetic area. And here I just continue where Hovey stopped. The problem is, okay, we have two scenarios. One scenario is a small vertical incisions are done. When we are doing small vertical incision, it's not only the scars, it's also that this transition area between bulky augmented tissue and adjacent tissue, it does not look good. It really doesn't good look. And it is especially true for narrow sites, like lateral incisors. If we don't do vertical incisions, when connective tissue graft is rolled underneath the buccal flap, this is what Hovey said, and now to see it, there is always this distance, this gap to the tooth, with risk of papillary recession and marginal gingival recession. It can be only temporary, but it can also stay. And the way to avoid it, it can be avoided is to mobilize flap over the adjacent tooth and to displace it coronally. And another way to avoid this papilla shrinkage is to utilize modified Palaci technique. Modified. It is only these semilunar flaps are not harvested from the buccal, like described from the Palaci. They are harvested and rotated coming from the palatal. Simply palatal semilunar incisions, and the flaps are rotated to cover the places between the implants and the teeth. And in this case, I planned to expand the reach utilizing Densabos and to improve soft tissue volume utilizing modified roll flap. But then all of a sudden, not all of a sudden, I had to do veneer grafting. And then I looked into my flap and thought, wow, great. I can utilize it. I can left it exposed. And this way, I don't need to do any coronary flap advancement of the buccal flap. Is it something new? I don't know. What I have found in the literature, and all my students have done really research, we have found that Mauro Merli published in his book this technique, but for another indication. This indication is implant uncoverage procedure, and this buccal sliding palatal flap is utilized to cover the inter-implant bone and to enhance the soft tissue volume. And this is what I saw with horror on Facebook, Source of the Knowledge, in July. And who posted it? It is the same indication, and this is the same approach, only much more elegant. It is no one other than expert Jorge Campos Aliaga. And let's see further with this technique, further improvement of this technique. I used to do it years ago, and then few months ago, when I started to collect material for this lecture, to think about this lecture, I remembered that I have done, but really badly documented, so I started again very intensively, and meanwhile, more than 25 patients done in this procedure, very typically rich expansion utilizing Densabos, veneer grafting, and then instead of coronary repositioning of the buccal flap, some connective tissue, peticulated connective tissue is left exposed. And it heals very good, of course. It heals really good because it is connective tissue and is peticulated. It has great vascularity. And now comes the I think, very good marriage. And this marriage is between the buccal sliding palatal flap and soft tissue augmentation. And this is what I have been done extensively now for months. It means implant is placed, GBR, healing abutment, and instead of the coronary flap repositioning, this buccal sliding palatal flap. Let's see, video to this procedure. The palatal tissue is splitted. Please pay attention that this splitting is extended here underneath the adjacent tooth. One horizontal incision, apically, two vertical incisions, and this connective tissue is released from the bone, and instead of rolling it underneath the buccal flap, we use it simple for the primary wound closure, avoiding any coronary flap advancement. And for the suturing, mostly horizontal mattress sutures, and sometimes I add single sutures, but mostly only horizontally mattress sutures. And this case, some of you will recognize it was really very, very thin, rich splitting was done together with veneer grafting with some partial extraction therapy. This is immediately after provisional was inserted, and of course some shrinkage, and I wanted to improve vertical soft tissue. And on the laterally, the modified roll flap was done with Palacci, and in anterior area, instead of placing healing abutment and uncover the implant, I placed healing abutment but covered it with the buccal sliding flap. And this way, we are going to have a good or more vertical soft tissue dimension without doing much harm to this patient. If you have already seen this technique, please speak now, because I'm about to finish a paper about it, and it takes a lot of time. Let's see what Nikola Tesla says. Of course, complications like with all other techniques, what I've seen, it is just the initial situation, okay, implant placement with healing abutments, and then it looked like this 1 week after the procedure, 2 weeks, 3 weeks, it was partial superficial necrosis. Why? Because it wasn't pediculated, incision was too deep here. And another is prosthodontically complication. For this patient, she is medical doctor. Procedure is done really how it should be done. My favorite with healing abutment, soft tissue augmentation, only 3 horizontal sutures, and patient came home and placed Essex that was done before ridge augmentation, and so partially healing abutment exposure, but it's not going to have a lot of consequences. So let me finish. Let me thank to all of you who contributed to this lecture. It's really great to be a part of Dental XP family, to meet all friends all around the world, to keep together. And the best thing is to work together, because coming together is only begin. Keeping together is progress, and working together is success.